Existe algum... tu modifica a tua avaliação pré-operatória ou é inteiramente baseada em ultrassom? Ou tu recomenda que se faça algum outro estudo? Quanto que consegue se dissecar a artéria carótida interna para fazer essa técnica com segurança? Existe algum grupo selecionado que tu ainda utiliza o PET?
The workup for these patients is the same. We right now use an ultrasound and a CTA to evaluate these patients. Rarely go to an angiogram. Patient selection, I think, has expanded, much like use of endografts has expanded over the past 10 years. Originally, we would look only at those patients who had very segmental bifurcation disease, and that was decided at the time of surgery. When you expose the carotid artery, you can see a yellow atheromatous plaque at the bifurcation. As you look more distally on the internal, you can see a transition from that yellow plaque to a purplish hue in the normal internal carotid artery. So it was those patients that had very short lesions that we did this on. This is also an excellent technique for patients who had redundant internal carotid arteries, because as you dissect out the internal carotid, it actually elongates, and you can shorten it without having to do application or do any other maneuvers, which can also cause some technical issues. We found it that as we became more comfortable with this, we would go into longer lesion, and now there are very few lesions that we go on to a patch closure, except for potentially redo carotid endarterectomies, although we've done about a third of those with re-eversion endarterectomies.
Clem, can I ask a question?
Ok. Parabenizá-lo pela elegante apresentação, belíssimo vídeo. Eu gostaria de perguntar qual é a incidência de placa alta em que sobra um flap proximal. E se tem esse flap, se você trata normalmente colocando um stent, isto, por exemplo, o Dr. Chiesa, de Milão, tem uma grande experiência também nessa mesma técnica, ele tem uma incidência de mais ou menos de 7 a 9% da necessidade de um stent intraoperatório. Gostaria de saber a sua experiência sobre isso.
That's a great question. As you probably guess, the incidence is dependent on how aggressively you look for it. If you do intraoperative ultrasounds, you will see flaps probably around 3 to 5% of the time. We are very vigilant about making sure the endpoint is fixed. If there is a flap that we see, we will actually re-evert it and try to either tack the endpoint. We've only had to put stents in a handful of patients, but I think that's an excellent technique, and that's one of the benefits of this technique, because you're putting a stent into a relatively straight internal carotid artery, which makes the access much easier. The distal fixation point is a leap of faith when you first start doing this procedure, because we're all used to looking at the carotid when it's open in an anterior-posterior dimension. So you don't, when you're looking straight down the end of an internal carotid artery, you do see a segment, or that's a step off that looks like it may potentially become a flap. Excuse me. But the chances of that really occurring is very minimal.
So, Clem, can I ask a couple questions? One was, do you do any intraoperative assessment because of this potential, at least for the appearance of a flap? And secondly, is this technique, can it be applicable to radiation arteries, radiated arteries or not?
Yeah, radiation arteries it does not, the plaques don't separate, and actually they kind of meld together, so it's very difficult to do. And getting back again to Dr. Lobato's question, there are many different versions of the eversion technique, and I'll talk a little bit about it tomorrow. DeBakey was one of the first to write about it, and he did a transection of the common carotid artery. The French have written about doing our technique, but also making a transverse incision distally on the internal in order to tack the plaque down distally. We've not adopted any of those. What was the first part of your question? I'm sorry.
Just whether you did any intraoperative assessment.
Yeah, the intraoperative assessments, originally we started out with handheld Doppler, which was just a very crude measurement. It would only tell you essentially if it was open or thrombosed. We've gone on to using more of the hockey stick kind of intraoperative probe to see. What we look for is not just a step off, we look for a flap that's actually moving before we do anything.
Do you think that type of assessment is required for this technique? 'Cause I don't use it for a patch technique. I just use a continuous wave.
Yeah, no, we use the intraoperative Doppler less frequently than we do the handheld Doppler, continuous wave. So no, I don't think it really is. Our results have been, as you'll see tomorrow, been very good. We've had very few early thromboses. I think you can predict those. In those cases when you have an extremely long lesion, even a patch closure is going to be somewhat difficult because you're going to be sewing into a smaller, somewhat narrow distal internal. So I don't think we have a good solution. A stent may be a better solution, but for that type of lesion. And again, we've actually backed out of 2 carotids that I know of in the last 15 years where we thought they were too calcified or that the plaque would not end, and we ended up stenting those patients as a secondary procedure.
Yeah, I have one question, if I may, and a comment. Can you hear me? Yeah. Can you hear me?
I can hear you.
Right. All right.
I don't know if that's good or bad.
I have, probably bad. I have definitely switched to the eversion technique after doing actually close to 3,000 carotid endarterectomies the standard way with a patch. I love this technique, but it's not so simple in some cases. It is technically demanding, and often we find patients that have not redundancy, but actually a very tight internal carotid artery, that when you transect, you hardly have much space to bring it together. And these are the most challenging cases, that if you're not careful placing those stitches in the heel, you end up stenosing it by tension at the toe. So I think there are some techniques, some technical challenges with the case, but certainly it's at the end of the procedure when you look at normal anatomy, starting all over again, you think that the patient has another 30, 40 years before he develops a stenosis. And regarding completion angiogram, my comment is completion duplex, it is important. And you're only going to give realize the importance of the duplex scan when you do consecutive cases on the hundreds. Then you'll find out about 2% have significant stenosis, but they're clinically unsuspectable. So I think it's a good idea. It doesn't take much. It takes 2 minutes. By the time you finish the duplex, the oozing stopped, and you have some document that your technique actually is good.
They're both very good points. Actually, we did a prospective prospective study early on, and one of the interesting parts about the eversion is we found that most of the recurrences, especially in our early part of our experience, were at the common internal junction as opposed to the distal internal as you see in most patch closures. And I think a lot of it was because we didn't pay attention. If we had a longer lesion in the common, now we clean out the common very actively, we actually would make a longitudinal incision on the common, clean it out, form a linear primary repair there up until the point where we can leisurely get the internal to fit onto the common. Also, if you free up a little of the common, a little of the external, it actually comes out a little further, so it takes some of the stress off of that. But I agree, every one of our techniques, where an endovascular open, has to be meticulous and well thought out. And if you just go in there thinking it's going to be an easy operation, you're always going to be paying for it at some point. So thank you very much.